السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. اللهم صل وسلم على نبينا محمد. I am Dr. Muhammad Abdul Ati, cardiac anesthesiologist, King Abdullah Medical City. It is a pleasure and honor to introduce basic practical ROTEM interpretation for you. I don't have any conflict of interest. I don't receive any money from any of the companies received. So I will talk about. Before we start, I would like to ask a question. What is the clinical value of viscoelastic TEG or ROTEM in critical medicine? And this drives us to the European Society of Intensive Care Medicine guidelines, the transfusion strategies in critically ill patients. In massively bleeding adults or non-massively bleeding adults, they emphasizing on either viscoelastic or conventional coagulation testing to guide transfusion in patients. So the evidence for that ranging from low quality evidence or very low quality evidence with conditional recommendations. So is there any benefit of viscoelastic TEG or ROTEM over conventional coagulation testing? And the answer is from the same guidelines. They stated that the use of viscoelastic testing may reduce transfusion-related acute lung injury or ARDS and decrease platelet transfusion, fresh frozen plasma transfusion. What about in cardiac surgery? We have ROTEM in cardiac surgery. So the European Society of Cardiothoracic Surgeons and Cardiothoracic Anesthesiologists in their guidelines is stating that perioperative treatment algorithms for the bleeding patient based on viscoelastic tests should be considered to reduce the number of transfusion. And reminding you the phrase is should be considered. It's a very strong statement with a class of recommendation of 2A with level of evidence B. On the other part of the world, in the Society of Cardiovascular Anesthesiologists, the recommendation, the practice advisory management of perioperative bleeding and hemostasis in cardiac surgery patients, they are stating that viscoelastic coagulation tests are superior to conventional coagulation laboratory results in guiding transfusion therapy in patients undergoing cardiovascular surgical procedures. So for me, after 3 years of interpreting TEG and ROTEM, I went through different milestones. At the beginning, I stick to the algorithm from the TEG company. Then the company changed and we have new machine with new different algorithm with ROTEM. Then some results from even in the TEG or ROTEM do not fit in the management algorithms, and this pushed me to dig more in the basics of interpretation rather than direct application of a printed algorithm. That's why came the title of this lecture, Basic Practical ROTEM Interpretation. The outline of this lecture, we will go through briefly basic review of hemostasis, then qualitative analysis of ROTEM. After that, we'll go through quantitative analysis. We'll have some real practical cases and ending by hyperfibrinolysis signs by ROTEM. In terms of management, what we will do for a bleeding patient in cardiac OR. Again, I am cardiac anesthesiologist. I talk about cardiac OR, main of my practice. So the bleeding patient in cardiac OR, either to give him tranexamic, protamine, fresh frozen plasma, or prothrombin complex, and reminding you throughout the lecture, once we say fresh frozen plasma, it is fresh frozen plasma or prothrombin complex, and we know that the prothrombin complex is better. And we can give fibrinogen or cryoprecipitate. We can give platelets, or if no medical apparent, we can ask the surgeon, likely this is a surgical bleeding or last resort off-label use of Novo-7 activated factor 7. I know this is very basic, I want to pass through it. So once we have a vessel injury, a vascular injury, there is vasoconstriction. Collagen will stimulate platelet activation, resulting in platelet plug. Tissue factor will be released, activate the coagulation cascade, ending by formation of thrombin that work on fibrinogen, resulting in fibrin. Fibrin, platelet plug form the platelet clot. Taking in consideration that at the same time there is blood clot formation, as we said, at the same time there is blood clot degeneration, which we call fibrinolysis. In terms of coagulation factors, we have the extrinsic pathway, factor 3 and 7, intrinsic pathway, factor 9, 11, 12, and the common pathway is factor 10, 5, 2, and 1. So now what is the normal ROTEM graph looks like? This is a real picture from our ROTEM machine displaying what is the normal ROTEM graph. And the first parameter here I would like to discuss is the x-axis of this graph. The x-axis of this graph represents the time. And the first time here represents the clotting time. And it is responsible by coagulation factors or anticoagulants. And I mean by anticoagulants in this lecture, mainly heparin, mainly the heparin. Taking in consideration that the abnormality here is prolongation of the time. There is no problem or no pathology associated with shortened time. So if you found this clotting time more prolonged, you expect to have problem in coagulation factors or heparin, and consequently you treat with fresh frozen plasma or protamine. Taking in consideration, the more prolonged the time, the more is the deficiency. On the other axis, this y-axis represents the amplitude. The unit is millimeter. And at the beginning of the curve, as you see, this represents the clot strength. And the part of hemostasis responsible for that is platelets and fibrinogen. Clearly, the abnormality here will be less number, less amplitude. And the less the number, the more is the deficiency in platelets or fibrinogen. At the end of the curve, there is another parameter here. It also amplitude decrease. It is amplitude also, and this represents how much the decrease in the amplitude at the end of the curve. This represents the lysis or clot degeneration or fibrinolysis, and clearly, the less the number, the more severe is the excessive fibrinolysis, and consequently, this should be treated by antifibrinolytic, which is tranexamic acid. Now, the question is, if the clotting time is prolonged, how can I differentiate between giving protamine or FFP? On the other hand, another question, if the amplitude is less, this amplitude is less, how can I differentiate between giving fibrinogen or platelets? And actually, these two questions drives us to the 4 graphs of ROTEM. We have 4 graphs of ROTEM. As you see here in this graph, okay, the first one on the right upper hand is the XTEM. XTEM is testing the extrinsic coagulation pathway. The second one is FIBTEM, and from its name, it represents the fibrinogen component of the clot strength. Third one here is the INTEM, which tests the intrinsic coagulation pathways. Last one on the right lower part of the screen, this is the HEPTEM, which study the effect or demonstrate the effect of heparin in patient blood sample. These are the 4 graphs of ROTEM that I spoke about in the previous slide, in the last slide. And here you can see this is a picture also of the cartridge we are using. We have two types of cartridge. This is the one with HepTim. If you open this, you will find this is the cartridge. You will find this is the cartridge. The saturated blood sample will be put here. Then the blood will go through HepTim, NTim, XTim, FibTim, and as you see, lot of cups and bins, taking in consideration that each cup contains different activator, like, for example, tissue factor, tranexamic acid, or heparinase. As I mentioned before, we have two types of cartridges. One is HepTim, contains FibTim, XTim, NTim is common in both, one with HepTim and the other one with ApTim. And this is the graph of HepTim, and this is the graph of ApTim. Me, as a cardiac anesthesiologist, in our cases, we give heparin. So we are concerned to have, concerned to have HepTim in our place. Regarding ApTim is like XTim, but it contains in its cup tranexamic or aproteinine, which is anti-fibrinolytic, and this confirm the ApTim confirm the excessive fibrinolysis that should be treated with tranexamic acid. We done with the first part. Now I will go through the qualitative analysis of ROTEM. Before numbers, qualitative assessment comes first, and it is very important also. So this is a graph here of ROTEM. I emphasize on the two green dotted lines here. The two green dotted lines here represent a normal amplitude, a normal clot strength of the graph. So clearly for this patient, for this graph, this is a normal clot strength. Looking to this example, this is a good amplitude because it is exceeding the two green lines, a strong clot. While looking at this one, we can appreciate without memorizing numbers, without looking to the numbers, that this is not reaching the green dots. So this is a less amplitude weak clot that should be treated with platelets or fibrin. Taking another example, as you see here, this is a good amplitude strong clot, and it is lasting for a long time. This is a long-lasting stable clot because as you see here, till 50 minutes, it is very strong one above the green lines. Looking here, you can appreciate that at the beginning, there is good amplitude, strong clot, but very early, we can see early lysis, short-lasting, unstable clot. This represents excessive fibrinolysis that should be treated by tranexamic acid. Back to what is the benefit of ApTim cartridge. If you look on one patient with early lysis, unstable clot of hyperfibrinolysis in the XTIM, if you look at the ApTim of the same patient, the ApTim containing tranexamic acid in its cup normalizes back the hyperfibrinolysis in XTIM. So this gives me a confirmation of diagnosis of hyperfibrinolysis, and as we mentioned, should be treated with tranexamic acid. Putting all together, this is the normal, this is the hyperfibrinolysis, and this is the weak clot that needs platelets or fibrin. Now we will go through the quantitative analysis. And now it's time to talk a little about the numbers. So talking about numbers, these are the numbers. These are the real graphs of what we get from the machine. I have now good news and bad news, and I will start with the bad one. The bad news are there are at each screen many numbers to look around. However, the good news is we most of the time look only to 5 numbers only. Not only this, but also if you look to the first 3 numbers and find it is normal, you don't need to look at the 4 and 5. So what are these numbers? The first one to look at in the right upper is the clotting time of the extem ROTEM, clotting time extem. Then the second one here is the clotting time in TIM in the lower left. After that, I will look again to the amplitude at 5-minute extem. If these 3 are normal, I don't look after. And if there is problem, I will look to the fourth one, which is clotting time heptim. The fifth one will be the amplitude 5-minute heptim. Let's take more explanation. So this is a graph of the extem. As you see, there are many numbers. We will look only to the clotting time extem. The normal is not to be prolonged than 80 seconds. Please note that the normal is down, plotted down. You don't have to memorize it, but for the sake of the lecture and the interaction, you may think about memorizing it. And remember the second thing, there is a range, low and upper. Lower range and the upper lower limit and the upper limit. We are concerned in the clotting time not to exceed the upper limit. The other one is the amplitude at 5 minutes amplitude extem. Taking in consideration amplitude extem should not be less than 35 millimeter. Again, in this amplitude, I watch the lower number. I don't look for the high number because the lower number represents the weak clot. Third, and this represents, this yellow arrow represents the amplitude at 5 minutes. Then the third number to look at is the maximum lysis, which comes at the end of the curve, taking in consideration that the maximum lysis should not exceed 15% normal. Let's look at this example. This is a graph of one patient, extem. You can appreciate that the clotting time here is 114 seconds, 114 seconds. So we have prolonged clotting time extem. This means problem in extrinsic pathway coagulation factors, so consider giving fresh frozen plasma. In the other example here, looking to, this is an extem, the amplitude at amplitude 5 minutes extem is 23 millimeter. What do you think about this 23 millimeters? It is way less than the 35, the norm. So we are in the weak clot pathway. This should be treated by fibrinogen or platelets. How can I figure it out? By looking to the A5 fiptim, the amplitude 5-minute fiptim. Looking to what is the normal A5 fiptim? The normal A5 fiptim should not be less than 9 millimeters. And reminding you, amplitude 5-minute fiptim represents the fibrinogen component or fibrinogen part of clot strength. Looking to this previous example at which the extem A5 was 23, was lower than 35, so we are between platelets or fibrinogen. Looking to this example, the first example here, the amplitude 5-minute fiptim is 2, means that there is poor fibrinogen contribution in the clot strength. So what treatment should be is to give fibrinogen. In another example, if you look here, you can appreciate the fiptim, the amplitude at 5 minutes is 15, is within normal, is more than 9 millimeter. So we have Now we have a weak clot with normal fibrinogen component. So what should be the treatment? The treatment should be give platelets. So to sum up what we have done, we done with the clotting time extem and amplitude 5-minute extem and amplitude 5-minute fibtem. So congratulations, 3 numbers of analysis has been done. Now we are left only with 2 parameters of the file. Clotting time in TIM here and clotting time HIPTIM on the lower right. So what is the normal? What about clotting time in TIM and HIPTIM? Again, clotting time in TIM represents the intrinsic coagulation pathway plus heparin anticoagulant. And normally it is number below should not exceed 280 seconds, nearly 5 minutes. And regarding the heptim, reminding you the heparinase in the cup neutralizes in the cup of heptim. The heparinase in the cup of heptim neutralizes the excess heparin in patient blood sample, so it normalizes the clotting time if there is excess heparin. And the normal is the same as in TIM. It is should not exceed 280 seconds. Again, heptim is like in TIM, but it contains heparinase in the cup, and heparinase in heptim neutralizes the heparin in patient blood sample. Let's take an example. We have here in this example of NTIM, ROTEM, you can appreciate the clotting time is 497 seconds. It should not exceed, is this normal or prolonged? This is prolonged, it should not exceed 280. So I have prolonged clotting time in TIM more than 280 seconds. So I have deficiency intrinsic coagulation factors or effect of heparin should be treated by protamine or FFP by looking to the this example, this heptim. You can appreciate that heptim or heparinase in the cup of the heptim normalizes the clotting time that was increased here. So it becomes back to normal. If the heptim or heparinase normalizes the clotting time back to normal, so the patient was having clearly residual heparin, so should be treated with extra protein. While looking to that example, you can appreciate that heptim did not normalize the clotting time. So we have prolonged CT heptim, clotting time heptim more than 280 seconds. So this is likely intrinsic factor deficiency. Consider giving fresh frozen plasma or PCC as we mentioned before. To sum up, we can appreciate the most important parameters we look at is clotting time, 5 numbers, clotting time extem, clotting time intim, amplitude 5-minute extem, clotting time heptim, and amplitude 5-minute fibtim. And this is if you want to take photo for the weak clot workout that we mentioned before. And this is for the prolonged clotting time workout that we mentioned before. Congratulations. We are done with the 3 above items, and now it's time for real practical cases. All our real practical cases are bleeding in cardiac surgery OR because, as I told you, I work in cardiac OR. So, case 1, this is a case of cabbage, and before sternal closure, surgeon said the field is bloody, patient was on Plavix, ROTEM done. Taking in consideration the blood pressure, pH, temperature, hemoglobin are all within range, are okay. So let's analyze. The first number to look at is the clotting time extem. It is 71. What do you think? Is it prolonged or not prolonged? I think it is normal. The other number to look at is the clotting time in TIM. Clotting time in TIM is something that is 274, that's to say less than 280. This is normal. Looking to the third number, which is amplitude 5-minute extem, you can see it is 45 millimeters. That is more than 35 millimeter. That is normal. So the three parameters I look for are normal. Shall I look to the fourth and fifth? The answer is no. So the numbers are okay. The three above numbers are okay. So this is a normal ROTEM. So from the medical point of view, field is bloody, and the medical point of view, the ROTEM is normal. It is likely to be a surgical cause of bleed. Going to case 2, here we start to see we have a lot of reds here. The computer, the machine is a stupid machine. It gives you color alarm either on either side of the range. So I have here one abnormal, one abnormal, one abnormal. But actually, what I have to look is different. I have to look at the clotting time extem is normal. Then I have to look to the clotting time in TIM, which is also normal. Then I will have to look to the amplitude 5-minute extem. Amplitude 5-minute extem is 55. It is 55 millimeter. It is above the normal amplitude. So what do you think? Do these patients represent a weak clot? The answer is no, because the significant value of A5 amplitude at 5 minutes is to be lower, not higher than. And consequently, if the patient had bleeding and normal blood pressure, pH, temperature, or hemoglobin, likely this is a surgical bleed. This case is a very strong example of the power of basic principles rather than looking to abnormal color on the screen. Sometimes you may look here, and if you are not concentrating whether you are interested or the number that makes sense is less than 35, you may be misled and interpret as to give platelets or fibrinogen and go to the next step, which is not the case. Going to the third example, again, case of cabbage, bleeding, and now let's analyze. Looking to the clotting time extem, it is 68, which is normal. Going to the amplitude at 5-minute extem, amplitude at 5-minute extem is 50 millimeter, which is also normal. What about the third number? The third number is clotting time in TIM, 338. So it is way prolonged than 280 seconds. Okay, if we have this number is prolonged, we look to the clotting time in TIM, HEP-TIM, I mean, sorry. Looking to the clotting time HEP-TIM, it is also prolonged. It is 303 seconds. So taking in consideration here, the clotting time in TIM is prolonged, the clotting time HEP-TIM is not normalized and prolonged still. So rephrasing this, after eliminating the effect of residual heparin, still the clotting time HEP-TIM is prolonged. So what is the line of treatment now? There is deficiency in coagulation factors, likely intrinsic coagulation pathway, and consider giving fresh frozen plasma. There is a question here, because as you see, the clotting time here in the intim is 338. In the HEP-TIM, at which, again, there is heparinase in the cup, it decreases. The heparinase in the cup of HEP-TIM decreases the clotting time to 303. It is less, but how much less is significant? This drives us to the question, how much the clotting time HEP-TIM should be less than clotting time in TIM to treat by extra protamine? And this part is not mentioned in the previous slides. So please take about a consideration of that. How much the decrease in heptim is considered significant to give extra protamine? And this is the answer. If the clotting time in TIM ratio divided by clotting time heptim is more than 1.25, give extra protamine. For example, in this previous example, if you calculate the ratio, 338 divided on 303, it is 1.1, so don't give extra protamine here. Looking to another example, you can appreciate that in TIM here is the clotting time in TIM in that example is 1,900 divided by clotting time heptim, which is 197. You can appreciate the ratio is around 10. So in this example, give extra. Going to the fourth and last case, looking to the clotting time extem, it is 94. So it is prolonged. So consider giving problem in extrinsic pathway, consider giving FFP. Then looking to the amplitude at 5 minutes, it is 24. What do you think about 24 millimeter? It is low. This needs to have a look on the FIBTIM, the A5 FIBTIM. A5 FIBTIM is 10, which is in the normal range. That's to say, the fibrinogen part of this clot is within normal. So if the A5 extem is low, meaning that I am in the weak clot workout, and the A5 FIBTIM, that's to say the fibrinogen component is normal. So what is the treatment? The treatment is to give platelets. Looking to the lower number, the third number here, in TIM, clotting time in TIM, it is 4,000, way more than 280 seconds. As you see, this is a flat line here. Right. Looking to this is too much long time. Looking to the heptim, you can appreciate it is just a 500. It is way less, but it is not normal. Getting the ratio in consideration, you can appreciate the ratio is 8. So extra protamine is warranted. Not only this, but heparinase in the heptim did not normalize the clotting time. So also there is a deficiency in coagulation factors, intrinsic pathways. So consider giving fresh frozen plasma. Last part of the lecture is what about the hyperfibrinolysis in critical? What are the ROTEM signs of hyperfibrinolysis? First, do you think that hyperfibrinolysis in critical medicine is important? And for me, from my basic knowledge, I think yes, because we face a lot of cases in critical medicine at which the diagnosis of hyperfibrinolysis is thought about. So, in ROTEM, what are the signs of hyperfibrinolysis? We mentioned one before in the qualitative, that we have a good amplitude and very short lasting early lysis clot. This is by qualitative. But looking to the quantitative also, you can appreciate here the maximum lysis is 11% here, the decline in the amplitude. While here, the maximum lysis is 100%. So the first important sign is maximum lysis, more than 15% within 60 minutes. Is there any signs? Other signs? Yes, we have. Other signs, the second sign is normalization of extem by aptem. Again, this is the hyperfibrinolysis seen in extem. And if you use the aptem cartridge, you can appreciate the normalization of the shape. And having a look to the number, here the maximum lysis is 100%. Here the maximum lysis is 0%. And again, this is a very important sign and a very important value of aptem cartridge in critical medicine. A third sign of hyperfibrinolysis is A5 amplitude 5-minute extem less than 35 millimeter. Let's see an example. On the left hand here, there is normal amplitude at 5 minutes. On the right hand here, there is low amplitude. It is amplitude A5 extem, low amplitude 23. But again, this is something raising a question. In the previous slides, you mentioned in the basic that A5 extem less than 35 millimeter equals weak clot formation. So you think about giving platelets or fibrinogen. Now, this gave me some time to think about it. Here, if we are going back to the major component of hemostasis, we should emphasize that the blood clot formation and the fibrinolysis or clot degeneration starts early at the same time. At the same time, vascular injury occurred, blood clot formation process started, and at the same time, fibrinolysis or clot degeneration process started at the same time. So, if there is excessive, this could be explained by early imbalance between fibrin formation, as I told, clot formation, and fibrin degradation in favor of excessive fibrinolysis. That's to say, in any patient with A amplitude 5 extem less than 35 millimeter, give antifibrinolytic, which is tranexamic acid, plus going to assess the need for platelet or fibrinogen according to the data in the A5 extem and A5 FIBTEM, as we mentioned before. Fourth and last sign of hyperfibrinolysis, if you look here, we look at the FIBTEM. You can appreciate the clotting time FIBTEM is 61 seconds, which is normal. Looking here, what is the sign? The sign is clotting time FIBTEM more than 600 seconds. Or you can say the clotting time FIBTEM is a flat line. See, there is no any fibrinogen or platelet clot forming here appreciated, formed. So this is way too much excessive fibrinolysis. Very severe fibrinolysis to the extent that even no clot starts to form. Very early and very, very excessive fibrinolysis process. In summary, the signs of hyperfibrinolysis, the first one, maximum lysis more than 15% within 60 minutes. Second one, normalization of extem by aptem. Third one, the amplitude 5-minute extem less than 35 millimeter. Fourth one, the clotting time FIBTEM more than 600 seconds, or clotting time FIBTEM is flat line. And I believe personally that hyperfibrinolysis is a spectrum starting from sign 1, this is less severe, to sign 4, which is most severe fibrinolysis. And in all, the treatment is to give antifibrinolytic, which is tranexamic acid. Take-home message. The latest guidelines of European Society of Intensive Care Medicine suggest use either viscoelastic or conventional coagulation test. As we mentioned, low quality or very low quality with conditional recommendation. The use of viscoelastic testing may reduce transfusion-related acute lung injury, ARDS, platelet transfusion, fresh frozen plasma transfusion. Algorithmic approach is very useful. However, algorithm does not reveal all the possibilities of results. The importance of basic knowledge, basic background comes here, and you are invited to a more advanced ROTEM interpretation in near future. Thank you.